Hello guys, in this video we'll be talking about the ECG. So what are the basics that you need to know and how can you easily identify ECG. So like I have included sample 20-30 ECGs that are most important to know. But before this we'll discuss the basics that will help you identify the ECG. ECG is one of the most confusing topic. So let's see how can we make it easy and we get the questions correct. So this is the aim for today. And guys, if you are new to this channel, please subscribe to the channel. Let's get started guys. Okay, when we talk about the ECG guys, the one thing that we need to know, the William Einthoven sir got Nobel Prize for his work guys. So this is important. Now coming on to the normal ECG, how does this ECG looks like guys? We have a P wave, QRS wave and the T wave guys. So the things that we need to know guys, we'll go step by step. First of all, this is the ECG interpretation paper. Okay, so see what happens. So the each you have a small in one large square. Okay, this is one large square, you have 5 small square. Okay, so see, this is the time interval wala square. So one small square is 0.04 second. So one large square will be 0.04 into 5. That comes out to be 0.2 second. Okay, that's written here, one large square. Okay, and this is 1 mm. So this 5 will be 5 mm and this indicates 0.1 millivolt voltage. So these were the things that you need to remember. Now coming on to how do you interpret the graph. So normally this reading it takes at a rate of 25 mm per second. Okay, so this is important, that reading is taken at 25. See, this we have already done 0.40 second and 0.2. That was important, one small square, large square, and the distance also we have seen. Now see, coming on to this interpretation, these are some normal values that we need to know. This PR interval, what does this PR interval mean? From the start of P wave, okay, to the start of the R wave, that is 0.12 to 0.20 second. Now coming on to this other intervals, that is like QT interval. So what does this QT interval means? Means from the start of Q wave to the end of this T wave, that comes out to be 0.40 to 0.43 second. And QRS duration you need to know. Okay, so these were the things that you need to know. So see, we'll read about PR interval, ST segment, QT interval. These are the things that changes in the ECG. So what does PR interval mean? See, this is actually the PR. From here the wave is starting, and the PR interval means this is actually the time, okay, taken from the impulse to reach from the auricles. Okay, see, to spread from the auricles to the ventricles. Okay, from reaching the SA node to the AV node. Okay, so this basically the time taken is basically the PR interval. Now ST segment. Okay, so see, ST segment, if we see, so ST segment is from the end of the S wave to the start of the T wave. Okay, and this QT interval. So QT interval basically, see, if you see, look at the QT interval. So see, this P wave represents the atrial contraction. This QRS wave represents the ventricular contraction, and this T wave represents the ventricular repolarization. Okay, so what does this will indicate QT? See, entire ventricular contraction, okay, that is ventricular depolarization and ventricular repolarization. All will come here. Okay, see, this QT interval, this denotes the ventricular depolarization and repolarization. And what is the normal QT? That is 0.36 to 0.45 second. Now see, now coming on to the placement of leads. So what are the leads? We have actually 3 bipolar leads. Okay, and we have limb leads, and we have this we have limb leads, and also we have some other leads, that is the precordial lead. Okay, so if we talk about the bipolar lead, that are the limb lead, we have 3 limb lead, that is 1, 2, 3. Okay, and we have 3 augmented limb lead, they are unipolar lead, that is AVR, AVL and AVF. And we have 6 precordial leads, that is V1 to V6. Now see, how are the leads V1 to V6 placed? So it's very simple. Okay, just start like this and go. Okay, see, first of all V1. So just make an image in your mind. V1, that is guys on the 4th intercostal space, that is 4th intercostal space to the right of the sternum, that is V1. Okay, then guys, then you have the V2. V2 will be the 4th intercostal space to the left of the sternum. Now come on to the V4. Now see, V4, V5, V6. First you have mid clavicular line, anterior clavicular line and posterior clavicular. Try to visualize mid clavicular, anterior axillary, and you have guys, then you have the left mid axillary line. Okay, so that comes out to be guys V4, V5 and V6. Okay, now coming on to where this V3 is placed. So this V3 is actually placed between the V2 and V4. Now think, if someone asks you V2, so V2 is where? That is placed on the fourth intercostal space to the left, guys. Okay, and this and V4 guys, V4 is in the mid clavicular line. Okay, fifth intercostal space. And you have one more, that is V4R. Okay, that is fifth intercostal space in the right mid clavicular line. Okay, see, then if you see guys, this is right arm, left leg, left leg. Okay, so remember RLN, right? You have a navna recurrent laryngeal nerve. This left leg is neutral. Okay, and you have right arm and left leg. Okay, now coming on to the electrode. This is basically the Einthoven triangle, the guy who was awarded the Nobel Prize. So what happens here? See, this is the right arm and left leg. Why? Because right leg is neutral, so we don't consider here. Okay, so from the right arm has a negative and left arm, so it goes like this. Then from the left arm to the left leg, so a triangle is formed. So this is the triangle. So this was the lead 1, this is the lead 2, this is the lead 3. If you recall your vector, if two leads are moving in the same direction, means 1 plus 3, and this is moving, so that will be equal to 2. This was according to your vectors. Oh, so we have already talked about the leads, that is precordial lead, bipolar lead is 1, 2 and 3, and unipolar lead, that is augmented, AVR, AVL and AVF. So this is basically how the ECG. This is 1, 2 and 3 lead. Okay, and this is AVR, AVL and AVF. So if we talk about the combined diagram, see, this was the lead 1, this is the lead 2, this is the lead 3. Okay, and this one is the lead 3. Then see, then we have AVR, AVL and AVF. So this is the AVF that goes towards the foot. This goes towards the left, and this goes towards the right. Okay, so what is important here? So see, I said 1 plus 3 will be equal to 2. So entire sum will be equal to 0, and 1 plus 3 is equal to 2. Already done. Now this is the most important thing that will help you identify the MI. So where is the location of MI? So we need to remember what are the septal group, what are the anterior group, what are the lateral group, what are the inferior group. Remember this AVR. Okay, that was AVR is none because it does not indicate. I have a 3D diagram which I'll be showing you guys. See, this is basically the 3D diagram. So try to see the heart is in the between. So now recall the lead position V1. V1 was fourth intercostal space. That fourth intercostal space on the right side. V2, fourth intercostal space on the left side. V3 was between the V2 and the V4. Then V4 was the fifth intercostal space in the mid clavicular line. Then you have mid axillary line, anterior axillary line, then mid axillary line. Do you see? So V1, V2, V3, V4, V5, V6 means V1 and V2 will give the appearance of the septum. This V3 and V4 will give the appearance of the anterior wall, and this V5 and V6 will give the appearance of the lateral wall. And we had 3 augmented lead. One was AVL, one was AVF, you see, and one was AVR. See, this AVR, there is nothing this side, so this is none. It does not indicate anything. This AVL, if you see guys, does it not come in the side of V5 and V6? Means this will also give a lateral view. And this inferior wall, if you see on the inferior side, this lead 2 and 3 is coming on the inferior side, and also this AVF comes on the inferior side. Okay, and so this was about your leads. Now how to make it easy? So we have a mnemonic. Remember this mnemonic, Sally. Okay, so Sally is basically the mother, means your mother, sister and other things. Okay, so see, Sally, how will you remember it? So S for septal, A for anterior, L for lateral, I for inferior, right, like this. Then right, there are 6 leads, right, V1, V2, V3, V4, V5, V6. Till V6 is there, it's done. Now after V6 guys, what do you have? You have 1, 2, 3. Okay, so 1 will come here in the lateral wala thing, and in inferior wala thing you will have 2 and 3. So how will you remember what comes in inferior? Remember inferior, that is in. If someone comes in, he will go out 2, that is 2 letter and 3 letter, that is 2 and 3. Lateral L, Here you will have AVL, and inferior F comes here, that is AVF. I think this makes it super easy to recall your all the position of means what part visualize. If now recall, someone ask you visualization of the lateral part, just think SALI, that is V5 V6. Okay, and then we will start the 1 2 3, means 1 will come, so V5 V6 1 and AVL because it's lateral. So if you see ECG changes in this, means this is actually the lateral MI. So this is, you need to know, this helps you identifying. Now see, if you see this chart, try to recall inferior, that is SALI, last wala, means you will have 2 3 and AVFC, 2 3 AVF. Now anterior, if you see, so anterior is SA, second wala letter, that is V3 V4, that is V3 V4. Now coming on to the anteroseptal, if someone asks, means anterior wala part bhi, septal wala bhi, means S और A दोनों आ जाएगा, so that is V1 V2 V3 V4. Now coming on to the lateral wala thing, so lateral SAL wala, so again it's guys like V5 V6 1 and AVL. So I think this helps you, and this is basically the arterial supply. So this is most likely the artery involved. So in inferior, it may be right coronary artery or the left circumflex artery. Anterior is left anterior descending artery. Anteroseptal, that is also left anterior descending artery. And lateral it may be either left circumflex artery or the left anterior descending artery. So this was that you need to know, and this is how the impulse transmit. So see, this is a segment that shows PR interval, ST interval, TP interval. So this we have already read. So this is summary. P wave is actually atrial depolarization. QRS is the ventricular depolarization, and T wave is the ventricular repolarization. And U wave, if we talk about, so U wave is due to the slow repolarization of the ventricular Purkinje fibers, and this U wave is seen in hypokalemia. So how can you remember? Remember U wave like underkalemia, means potassium has decreased. Underkalemia, you see U wave. Okay, so now how do you interpret the ECG? That is, first you need to check the heart rate, then the rhythm, then the axis, then the wave morphology, then if you have any specific chamber enlargement, some specific changes. So now coming on to the heart rate. See, checking the heart rate is very easy. So what we do in order to check the heart rate? So what we do, we have a formula, that is 1500 by the number of the small square, okay, between two RR interval. And otherwise other formula is 300 by number of large square between two RR interval. Now see, suppose this example, we take an example. See, this is the distance between the RR interval. Now count the large square, 1 2 3 4, and some part here and some part here. That will come out around somewhat around 5.4 square. So if you do, it comes out to be 55 beats around. Now count the small square. See, 1 2 3, then 5 3 8 13 18 23 and 4 27 square. That will also come around to the same thing. So this is important. Now see, in some of the question what happens when it is irregular. So how will you do? Means where the distance between each RR interval is not same. Here you see the distance is same. So what you do, there you count in time frame of 10 seconds. Okay, how many this R beats are there? Suppose we take this example, we have 9 beats in this 10 second wala graph. So in 10 second you have 9 beats. So assuming it will go like this, that in 60 second multiply by 6, that is 54 beats per minute. You see slight variation because that the graph is not so regular, so you will have some variation. So basically this is a similar example. You check here what happens, you have two large square, that is 300 by 2, 150 beats per minute. But here if you see you have 5 large square, that comes out to be 60 beats per minute. So what do you know here, guys? So this we have already talked about the irregular rhythm. Now suppose we take an example of this. You first of all check, are the RR interval equal? Yes, the RR interval are equal. Now count the number of large square, 1 2 3 4 5, and some part here and here. That will come somewhat around 5.2 5.3. That will come around more than 50 beats per minute. Okay, see, suppose we take this example. if we take the distance here, suppose see this one is the where we need to calculate. Okay, see what happens here. Calculate the distance between this two RR interval. That comes out to be 1 2 3 4. Okay, that comes out to be 4 large square, that is 75 beats per minute. So what is the normal heart rate? That is 60 to 100. Tachycardia more than 100 and bradycardia less than 60. Okay, see, now coming on to the rhythm. For a normal one, every every QRS wave should be followed by a P wave. Then it's known as the normal sinus rhythm, NSR. Okay, so this is important. See, what do you see here? Means it's followed by this, every QRS wave is followed by a P wave. Here when you see, it's not followed. See, it's continuous. So that is about the ectopic P wave. Suppose we take this example. First of all, we need to calculate the heart rate. See, are the gaps regular? If you see, yes, the gaps are regular. So that is equal RR interval, means this graph is in NSR, normal sinus rhythm. Now coming on to some of the variation if we talk about. Okay, so this was a normal sinus rhythm ka graph. Everything is normal here. So if you calculate the heart rate, see, try calculating 1 1 2 3 and some part 4.1, that comes out to be around 72 beats per minute. What is the normal? 60 to 100, means the graph is fine. Now coming on to when the condition decreases. So when can it decrease? Okay, bradycardia, when it's normally lesser in athletes and when you are sleeping or when you are under drugs like beta blocker. Now calculate. See, I think it's well understood. Like, see, if this value increases, overall value will decrease. See, here the distance is 1 2 3 4 5 6, that is 6 large square. So it's less than 60-50 beats per minute. That is sinus bradycardia. Now when will it increase? Think, when is the heart rate increasing, guys? When we do exercise, when we have anxiety, when we have fever. So see, here the gaps are so less, that is slightly the gap is so less, means only 8 small square are there, that is 187 beats per minute. So it's very fast, more than 100, that is tachycardia. Now coming on to the sinus arrhythmias. So what happens? Arrhythmia means there is some variation. Okay, see, if you see the gap, what happens? Do you see? We have a variation, increasing, decreasing. Do you see? There is a variation. So what happens? Normally it's between 60 to 100. But what happens? Heart rate increases with inspiration and it decreases with expiration. Okay, so this is important. But the other things are normal. So this the RR interval is irregular. Okay, so this is sinus arrhythmia. Okay, now coming on to the supraventricular tachycardia. What does name indicate? Supraventricular means above the ventricle. Okay, when auricle is contracting to the ventricle, passing the impulse, so there is some problem. Okay, so what happens? Suppose that there is tachycardia, that it's pumping so fast that all this P wave won't be distinguished from this T wave. Okay, what happens, guys? See, when this T wave ends, so you have a P wave, but it's so fast pumping that some of the P wave may be buried in your T wave. So that is important. That is, frequently they are buried in the preceding T wave and they are difficult to see. So this is important. But the QRS interval, if you check out, okay, if we check out the QRS interval, that is normal. There is no variation in your QRS interval. Now coming on to the PSVT, that is paroxysmal supraventricular tachycardia. So again it's a type of supraventricular tachycardia only, and this is also known as paroxysmal atrial tachycardia. See what happens here. Here what happens? Here the rhythm you see, initially it's regular, then it becomes irregular. Okay, so the rhythm is irregular, and here the P waves are absent. See here, are you able to find the P wave? No, it has got merged. But so this was important. Here the P waves got merged. So that is paroxysmal supraventricular. So what are the things that you need to know? Here the P wave is absent. Okay, that is important in paroxysmal supraventricular tachycardia. So see, when we talk about the tachyarrhythmia, means heart rate is ज़्यादा, so we look at the QRS. What does QRS indicate? About the ventricular depolarization. Okay, see, if the QRS is abnormal, void, means there is some problem with the ventricle. That is, it may be tachyventricular tachycardia, ventricular flutter fibrillation. See, if QRS is normal, means ventricle is fine. So now we need to check the P wave. What does P wave tells? P wave tells about the atrial contraction. Okay, see, so we will check whether the P wave is present or absent. Okay, so if the P wave is present, we need to check whether it is whether in every QRS is followed by a P or not. Okay, see, so if it is there, that is sinus tachycardia that was seen in fever, exercise and other thing. Okay, see, if each P wave is if each P is not followed by QRS, that is atrial flutter. Okay, if the P wave is absent but the rhythm is regular, that is PSVT, that is paroxysmal supraventricular tachycardia. If this P wave is absent and the rhythm is also irregular, that is atrial fibrillation. Okay, now coming on to atrial, see, we read about the atrial flutter and fibrillation. So first we'll see what is atrial flutter and fibrillation. See, if you talk about the atrial flutter, P wave is present. Do you see? P wave is there. Okay, but this looks like a sawtooth appearance. See, atrial flutter, remember, like a sawtooth appearance. Okay, and this P wave may be buried in the QRS wave. Do you see? So this is known as flutter waves. Okay, sawtooth waves are flutter waves. This is important. So this is atrial flutter, and each P wave is not followed by QRS wave because sometimes it may be buried. So this is important. Now see, when now we read about the atrial flutter. Now coming on to the atrial fibrillation, see the difference. Do you see the difference between the RR interval? So RR interval is not constant, that is there is irregular rhythm. Okay, and also you see each P wave is not followed by a QRS wave. Okay, that is P wave is absent if you see here. Okay, that's so there is no true P wave, that is P wave absent. So this is atrial fibrillation. Now coming on to the WPW syndrome, that is Wolff-Parkinson-White syndrome. So in Wolff-Parkinson-White syndrome, there is an extra pathway between the auricles and ventricle. Means when there is an extra pathway, so what will happen there, guys? So what are the things you need to remember? In this Wolff-Parkinson-White, you have the presence of delta wave. Okay, and here what we see? So here we have PR interval is short and delta wave is present. So these are the findings of Wolff-Parkinson. So how will you Parkinson, that is PR. So PR is prolonged here in Wolff-Parkinson. Okay, and you see the presence of delta wave here in Wolff-Parkinson-White syndrome. Now coming on to the torsidis dpointes. So what happens in torsidis dpointes? Okay, so basically what happens, this is seen in long QT intervals. Okay, if you check out the QT intervals that are long, and it is due to certain anti-arrhythmic drugs. So see here, you don't find any P wave. So this is like, remember this torsioidis dpointes, remember like a twisting points, means it's like a bend road, very twisted narrow road. So this is like a bizarre appearance, that is torsioidis dpointes. Now coming on to the ventricular fibrillation, which is not so important, so we'll now coming on to the heart block. Okay, see, for heart block, remember it like this. I think this makes it very easy. Okay, so you have heart block, first degree, second degree, third degree. Okay, first degree, second degree is divided into two types, that is Banke-Baj and you have Mobius type 2. So remember first degree, remember if R is away from the P, means this distance is increased. Okay, first we'll see this. Remember, see, first degree graph. So means R is away from P, means what do you understand by this? This PR is prolonged in first degree. Okay, so this is important. Do you see this PR? See the distance. What was the normal? That was 0.12 to 0. See the gap here, 1, 2, 3, 4, 5, 6. That comes at around to 0.28. That is prolonged. So if P is far from R, that is first degree, that is PR increase. Now coming on to the second degree, that is Mobius type 1, that is known as Banke-Baj. See what happens here, what happens, the PR goes on continuously prolonging. Okay, then you have a drop. See, the PR is progressively longer. See, this is the PR, this is the PR, this is the PR. Okay, the PR is progressively longer until one P wave is drop. Okay, it leaves off a P wave, that is second degree, which is known as Banke-Baj phenomenon. Okay, this is important. Now coming on to the second degree, that is type 2, that is Mobius type 2. So coming on to the Mobius type 2. Okay, that is if some P's don't get through, then you have Mobius type 2. Okay, when you come to the Mobius type 2, see, there is more P waves than the QRS wave. See, here what happens, the PR wave is constant. Okay, means what happens in type 1, see, this PR wave is progressively longer as you move, then it drops a P wave. Here the PR wave is constant, and here also you have more P waves. Okay, this is important. Now coming on to the type 3 block. Okay, when you come to the type 3, if P and Q's don't agree, okay, that is the type 3 block. Okay, so so see, this is also known as complete heart block. Okay, this is so the conduction between the auricles and the ventricle is totally absent because of electrical block at or below the AV node. This is known as AV dissociation. So okay, this is important. So here what happens, atria and ventricle act independently, they do not act in sync. So this is important in your third degree, means P and R belong separately. Now come revise once. Okay, heart block things. If someone asks you first degree, that is P and R moves away, that is PR increase. Now coming on to the second degree, type 1. So first में PR increase, second में PR progressively increase till a P beat is drop. Now now second degree, type 2. So PR is constant and you have more P's. Okay, now third degree, P and Q don't agree with each other, they beat independently. Okay, see, we have read most of this. Will revise. Atrial fibrillation. See, the beats are unequal. Okay, so this is important in atrial fibrillation. Okay, that the rhythm is irregular in your atrial fibrillation, and each P wave, each QRS is not followed by a P wave. Do you see? Now atrial flutter, if you see, this is the flutter wave or the sawtooth appearance. This is important. Okay, now see, this we have already read about the normal sinus rhythm. You can check sinus tachycardia, so heart rate is more. You can see it comes out to be more than 100. Then if you talk about the atrial flutter, so atrial flutter mein what happens, you have sawtooth waves, that is the multiple flutter wave. Okay, now coming on to the atrial fibrillation. So atrial fibrillation, each QRS is not followed by a P wave and the rhythm is irregular. Then ventricular tachycardia. So in when you have a problem with ventricle, so something will happen with the QRS thing. Okay, do you see the prolonged QRS, how much it is prolonged? That is ventricular tachycardia. So ventricular fibrillation. So ventricular fibrillation, you have no P wave, no T wave, and you have multiple QRS wave. Why? Because ventricle status is set by the QRS wave. So that is QRS wave. Then you have the first degree block. See what happens. PR interval is more than 0.2. What was the normal? 0.12 to 0.20. Now second degree heart block. PR interval increases. Okay, until it progressively drops a beat. Okay, that is type 1. So this was about your type 1 and type 2. See, this is about the first degree block. Second degree block, Mobish 1 or Bankeva. Second degree block, that is Mobish type 2. Then you have third degree block. See, first degree block. So what happens in first degree? That is PR is increased. Do you see the distance in PR? That is increased. Second degree, what happens? PR increase until you drop a beat. A beat is drop. Now here the PR remains constant, but you may have like more than one. Do you see? So this is important. So that is, you have two things inside. That is 2:1 ka ratio. 2:1 block. And third degree, what do you have? That they beat independently. Okay, third degree, the P and R are not in sync. So this already has been done. Okay, see, now what is important? Now coming on to how to find the axis. So this is the thing that is very confused. Okay, so see, we have already talked about the leads. Okay, you have V1, V2, V3. Okay, see, I have drawn a simplified V1, V2, V3, and you have AVR, AVL, and AVF. Okay, even so this is what, see, so what is the normal axis? This part minus 30 to plus 90 is the normal axis. What is right axis deviation? Right axis is plus 90 to plus 80. What is left axis? Minus 30 to minus 90. And extreme axis is 180 degree to minus 90 degree. Okay, this AVR is bakwas. It does not tell you any status of the heart. So how will you determine the axis? Suppose see, whenever someone asks you to determine the axis, you need to look at 1 and AVF. Okay, this will help you identify the axis. Okay, so this is important. So axis determination is by lead 1 and lead AVF. Okay, see, how will you, so check the lead 1, check the lead AVF. Okay, see, how do you determine? So we need to see where was AV1. I think if you might have seen my graph, see, this thing is important. AV1. Okay, this V1 was here. Okay, and AVF is here if everything goes fine. Okay, now let's plot accordingly. See, This is AV1. See, more positive up, less negative down, means overall its AV1 is, means V1 is positive, it will come this side. Now see AVF, this is more positive up and very less positive down, means overall it's positive. So AVF will also come down. So where does it come? This comes in the normal QRS axis, that is normal deviation. Okay. And then we'll have a mnemonic also. First try to understand, then we'll have a mnemonic. Now see, if you see this one, upside is more, that is it's positive. So V1 will come this side. Now coming to AVF, see, up it's less, down it's more, means AVF here instead of negative, it's here instead of being positive, it's negative, means it will go up. Means graph will come somewhere here. What does it mean? This will go in your left axis deviation. See, check. What is this? This is see how the graph is done. Do you see? Now coming on to the next one. Okay, see, check AV1 and AVF. See, AV1 it's less, down it's more, means it's negative. So this time it will go here. Now see, AVF is positive, so this will come here. So where does graph come? Here. That is, it comes out in the region of right axis deviation. Okay, see, so this comes out in, and this comes out to be the intermediate axis if you practice. So how will you remember it? Okay, so so there is a mnemonic. See what happens here, one of the graph is going up, one is going up, and this AVF wala is going down, means they are leaving each other. So remember, left leaves. Okay, now coming on to this one, see, this is going down, this is going up. Okay, that is right reaches each other. Okay, I think this helps you remember. Now see, we'll practice few more questions. Suppose we take this example. See, which is more? Above it's more. Okay, if you see the positive and the negative deflection, AVF above means both are going up. Okay, means it's a normal axis if both are going up. No one is reaching anyone, no one is leaving anyone. Now suppose we see this example. See, if we see the 1 and AVF, 1 it's more in the down wala part. Okay, AVF if we see it's more, means both of them are reaching each other. That is right reaches, hence it's a right axis deviation. Now coming on to what are the causes for right axis deviation, what are the causes for left axis deviation. See, when we read about the bundle branch block, there is a mnemonic William. Okay, so I wanna use a similar mnemonic, I don't wanna change the mnemonic. Okay, so how will you use this mnemonic William? Okay, so William means L comes here, means this is the mnemonic for left, don't get confused. Okay, so see, remember first of all the things where you see left, that is left bundle branch block, left ventricular hypertrophy, left anterior hemi block, left atrial hypertrophy, everywhere jahan bhi left aa raha hai, that is left axis deviation. Okay, then what you have? I means you have inferior myocardial infarction, then it's seen in hyperkalemia. Okay, then this is also seen in W, you may remember Wolff-Parkinson-White syndrome. Okay, this Wolff-Parkinson can show anything. So see, one of the thing is important, all the left comes here except one left, that is left posterior hemiblock, anterior comes here. So for right, what is the mnemonic? That is RALPH. A means anterolateral MI. Okay, LPH means left posterior hemiblock. Okay, this dextrocardia also shows right axis deviation. Okay, so this dextrocardia has a right, so remember Ralph Dio. Okay, you will remember the dextrocardia. Okay, so this is important here. So this was about your right axis and the left axis deviation. When we'll practice some question, we'll see. Okay, now coming on to the right bundle branch block and left bundle. First of all, say what kind of axis deviation is this? Right bundle branch block is an example of right axis deviation. Left bundle branch block is an example of left axis deviation. So here we have the mnemonic, that is William and Marrow. Okay, William means it's for left bundle branch block, Marrow means right bundle branch block. In left bundle branch block, okay, here we need to see two things, that is V1 and V6. Recall guys, what do we see in your, for determining the axis? We have lead 1 and AVF. Here you have V1 and V6. Okay, so William means in V1 it will occur like a W, and in V6 it will occur like a M. If we talk about the right bundle branch block, in V1 it will occur like a M. See, how does it appear? This appear like a W, that is in V1, and this appear like a M in V6. Okay, now see, this appears like a M, okay, in V1, and like a W in V6. Okay, so this is about your right and left bundle branch block. Now let's identify this. Okay, so when we try to identify, we need to look at the V1 and the V6. Okay, let's look at it. Okay, if we look at this V1 and the V6, so what happens in the V1 and the V6 here? So this pattern, this is V1 and this one is the V6. That is in left wala thing, that is your it will come your mnemonic. See, this forms a W. Okay, and this wala things V6 wala form a M. That is, this is a left bundle branch block. This is important. Now right bundle branch block. So right bundle branch block, if you have a graph of right bundle branch block, so what you have in right bundle branch block, that is in V1, see, first it goes up, that is M. In V6 first it comes down, that is W. Means that forms a marrow, means it's a right bundle branch block. And this QRS duration is more than 120 millisecond. So this has been already done, right bundle branch block. See, then what we have here, this is the left anterior fasci block. Okay, left anterior or left anterior hemi block. Okay, fascicular block or the hemi. First, see, when entire graph is try to take out the axis, that will help you a lot. See, AV1 one is positive and this both are leaving each other, means it's a left axis deviation. So most likely कुछ left का cause होगा, left anterior block, left ventricular hypertrophy, something like left का ही होना चाहिए. ठीक है, this we can think. Yeah, तो I think it will rule out some of your like possible diagnosis. Okay, so inferior वाला MI हो सकता है if left, because what was the mnemonic for left? It was, our mnemonic was William. Okay, so when you look here, guys, okay, that is, you find out the axis. So this graph is seen in basically left anterior fascicular block or the left anterior hemi block. So this is important. Now left posterior hemi block, remember the mnemonic RALPH, means this is the right axis deviation. Let's find out the axis. See, 1 and AV6. See, what happens, both of them are reaching each other, that is right reaches, that is, this is an example of right axis deviation. Okay, see, there is a right axis deviation of 90 to 180 degree. So this is important. See, this first degree AV block already done. What happens in first degree? This PR is prolonged and each P wave is preceded by a QRS wave. That is fine. Second degree type 1 block, also known as the Benke watch block. What happens in this Benke watch? PR is prolonged unless it drops off of beat. Then second degree type 2. Here the PR waves remain constant, though you may have multiple waves in between. So that is important. Then you have third degree, when you have asynchrony between the auricles and the ventricles. Now see, coming on to this chamber enlargement. Okay, so chamber enlargement, so what can happen? You can either have the left atrial enlargement, okay, or you can have the left atrial enlargement, or you may have the or you have had the right atrial enlargement. Okay, so see, when you have the chamber enlargement, okay, see, suppose we draw this heart. Okay, so when we draw the heart, this is the left atrium, left ventricle, right atrium, right ventricle. What is this? This is the tricuspid valve. This is the bicuspid valve. This bicuspid valve is also known as the mitral valve. So when we talk about this left atrial, so the name is P mitral. Okay, and if we talk about this, here we have a pulmonary valve, so the name is P pulmonale. So this is what we need to know. Atrial, remember someone asked you left atrial, I think on the left side we have the mitral valve. See, that is left, that is the mitral valve. Okay, so right side we have the pulmonary valve, that is P pulmonale. So what happens in left atrial enlargement? When you look at the wave V2, left atrial, that is M. Okay, P mitral. So remember, this M is like a M, that is notching. So there is a bifid P wave, that is notch. When you see the right atrial, that is P pulmonale, so the amplitude is higher. That is important. This is the left atrial enlargement. Do you see the bifid wala graph? Left atrial, remember someone left atrial means atria side mein, that is mitral. So there is a notching of the wave. Right atrial, that is P pulmonale, that is, it's more than 2.5 mm. Now coming on to the what are the ECG findings in the right and left ventricular hypertrophy. For this left ventricular hypertrophy, we have a very important criteria, that is known as the Sokolov-Lyon criteria. So what is in accordance to this criteria? S wave in V1 plus R wave in either V5 or V6 should be more than, like, if when you count it, it should be more than 0.35 millivolt. Okay, that is important. See, let's try counting it. Okay, so S wave in so it's basically you have S wave in V1 plus R wave in V5 or V6. Okay, see, we took V5. Now try to count the box. I think you will get it. See, that is 5, 10, 15, 20, 25, 26, 27 box के around है. And this comes out to be 12 box. That is, it's around 37 box. It's more than 35. So this is important. Left ventricular hypertrophy will show left axis deviation. Let's try to find out the axis also. So we will take V1 and AVF. Where is the AVF? Let's see. Now let's try finding out. See, what happens? This is positive above and this is also positive above. Okay, so I think there is some problem with this ECG. I'm not very sure, because this does not seems to fit in your left ventricular hypertrophy ka ECG, because AV1 and AVF both are going positive. So this does not, this looks like a normal axis deviation. It's fine. Maybe some problem with the ECG. Okay, and this is S wave in V1 plus R wave in V5 V6 more than 35. Also you have other criteria, that is modified Cornell, in which R wave in AVL is alone more than 12 mm. So now coming on to this right ventricular hypertrophy. So what were the criteria for right ventricular hypertrophy? This R wave in V1 is more than 0.5 millivolt. One criteria can be this. Okay, R wave in, do you see, is it more or not? See how much it's increased. That is, R wave in V1 is more than 0.5 millivolt. You have the right axis deviation in this type of graph, and in right ventricular hypertrophy also P pulmonale may be present. It's fine, it's not a very specific thing. Okay, so so this was about your right ventricular hypertrophy. Now coming on to the poor R wave progression. See, what happens normally what happens is it goes immediately. Here this R wave is going too down. Do you see? It's dipping too down. So it's progressing poorly. So what is the cause? Remember, poor means that is late. L means there is left bundle branch block or the left anterior fascicular block. A means anterior myocardial infarction. T means tension pneumothorax. E means emphysema या फिर ECG leads misplaced. So this is your about your poor R wave progression. Now coming here to the MI. This already we have discussed the MI. Now practicing some of the important ECG. When I send the PDF guys on the group, you will find more of ECG. But here we will do most important ECG. Starting with this ECG. Okay, that is sinus tachycardia. First we'll have a look at the heart rate. Okay, when we look at the heart rate, you see the distance that is there. Okay, that has decreased, means heart rate is more than 100. It's around 2.5, means it's around 130 140. Each QRS wave is preceded by a P wave, means this is fine. PR interval is normal, means this is a sinus tachycardia. Now atrial flutter. Okay, let's try seeing the ECG. Do you see when you look at the ECG, you have so many like sawtooth appearance. Okay, that's the sawtooth pattern, and the RR interval are regular. If you look at the RR interval, it's fine, it's a regular RR interval. That is important in your atrial flutter wala thing. Okay, now coming on to the atrial flutter with then you have atrial fibrillation. Means what happens in atrial fibrillation? Every QRS wave is not followed by a P wave. Do you see? You do not find a P wave here. Do you see? P wave is not so consistent. So this is about your atrial fibrillation, and there is irregular RR interval. So now coming on to the other important that we need to know, that is torsoides de pointis. Remember, this was like a twisting road. Do you see the ECG? How twisted does it looks like? So this is about your torsoides de pointis, and remember this has a prolonged QT. Okay, now other ECG, that is Wolff-Parkinson-White syndrome. Remember, what do we remember? Parkinson, that is PR increase, delta wave seen. Okay, so this was about your Wolff-Parkinson-White syndrome. So what happens? You have the delta wave, and this Wolff-Parkinson here, it's a short PR interval. I'll confirm whether it's short PR or it's either increased PR. Wait, I think it's slightly either it was wrong or it is wrong here. I will confirm and tell you guys. Okay, then you have the digoxin toxicity. So what happens in digoxin toxicity? So so you have shortened QT interval, and this is important. This digoxin toxicity shows a hockey stick sign. So this is important here in digoxin toxicity. So that we need to know. Okay, so now coming on. So what we read till now, this hockey stick sign is seen in digoxin toxicity. Then this delta wave were seen in Wolff Parkinson White syndrome. Now coming on to the other one that is important. Okay, when we come on to the other thing that is important, that is if we come on to the right bundle branch block. So right bundle branch block, you have tall T wave in V1 V2. And see, right bundle branch block, what was your mnemonic? That is, we will remember the mnemonic, MADO. In V1 you will have M pattern, and in V5 or V6 you will have W pattern. Let's check it out. V1 you have the presence of the M pattern, and V6 when you look out you have the presence of the W patterns. Check out. Okay, so this is about your right bundle branch block. So like this you can identify some of the common ECG. Then you have left atrial enlargement. Thinking about the left side means it's mitral. So you will have the bifid and the notch wave. Do you see the notching? This is important. Right atrial, that is P pulmonale, means it's tall and peaked P wave. Pulmonale, peaked P wave. Okay, see the amplitude has increased. So this is important. Then left ventricular hypertrophy. So this was your criteria, that is known as the Sokolov-Lyon criteria, or R wave in AVL more than 11 or 12 mm. Then right ventricular hypertrophy. So in right ventricular hypertrophy, S wave in V5 or V6 is more than 7 mm, or R wave in V1 is more than 7 mm. Then coming on to the first degree AV block. See, first degree AV block already done. PR is prolonged. Each wave is followed by a QRS wave. Then Wenke-Bach, PR is prolonged until it drops off a wave. Then Mobish type 2, PR interval remains constant. Okay, and each P wave is not followed by a QRS wave. Do you see? Now third degree, there is no relationship between the P wave and the QRS wave complex. That is important. That is important in your this wala thing, in your third degree wala finding. So first degree PR prolonged. Then in Wenke-Bach, PR is prolonged until you find a drop. Then PR is constant in your type 2, that is Mobish. And in your third degree, there is no relation between the P wave and the QRS wave. So it is like not related. So remember guys, in Wolff Parkinson White syndrome, the one we got confused there. In Wolff Parkinson White syndrome, the PR is shortened. Okay, remember this. Okay, I got confused. This PR Wolff Parkinson is shortened, and you see the presence of delta wave. This is important. It does not get increased. Then coming on to the few other important CC. So what are the findings in your acute MI? I think this question has been asked like every time. You have peak T wave followed by T wave inversion. We have ST segment change, the most important thing that we talks about. Now see, when you look at this ECG, if someone asks you, try to first have a look at the ECG. What finding do you see? If you look at some of the lead, like try checking this lead, try checking this lead, do you find ST segment is elevated so much? So if you see this, so that is in segment 2, segment 3, and in segment AVF, this was which one? SALI, means this one, this is the inferior wall MI. Now see the next one. Where do you find, in which of the segment you find the ST segment elevation? Try to have a look here. So ST segment elevation, here you find. Then ST segment elevation you find here also. Then ST segment elevation is found here also. So see, V5 shows, V6 shows, also here V4 also shows some part of ST segment. Then this ST segment is seen in 1 and AVL. Try to see V5, V6, 1, AVL, all point toward lateral wall ka MI. Now coming on to this one. So here you see ST segment elevation in 1, 2, So ST segments elevation in 1 and 2, that is septal wall ka MI. Also here you see in V4, V3 and V4, so this may be also anteroseptal wall MI. Now see, this is so where do you see ST segment elevation? It's elevated in V3, V4, so most likely anterior to anteroseptal wall MI is seen here. So now coming on to the other important things that can be asked, that is changes that we see in electrolyte imbalance. So for this I have made a good mnemonic. Okay, hypothermia. So hypothermia in name OT comes. So when you see OT, what is there? OT, you have the surgeon who is working in JOS. Okay, that is J wave is seen. J. OS means Osborne waves is seen, and ST means surgeon temperature is high, ST segment is elevated. This is important for your hypothermia ka finding. Now coming on to the ECG changes and a few important electrolyte imbalance. See, we have hypokalemia, hyperkalemia. So for hypo and hyperkalemia, remember the push-pull effect. Okay, hypokalemia. So T wave नीचे गया, T wave inversion, ST segment का depression, and this prominent U wave, that is underkalemia वाला wave. Now coming on to the hyperkalemia. Hyperkalemia T को pick किया, means P को flat किया. Okay, one is going more up, that is then P wave will go down because T is going up. PR gets prolonged and QRS gets prolonged. This is important in your hyperkalemia. Now remembering this hypocalcemia and this hypercalcemia. Okay, so how I have remembered this? Okay, hypo means low calcium. Okay, so I have remembered it like a low caste. Okay, so when you are a low caste, okay, so what happens, we have a lot of reservation in our system, so they try to promote you up, that is ST elevated, QT elevated. Okay, when you are a high caste, no one gives you any bhav, like you are ignored, that is ST will be also depressed and QT will also be depressed. But widened T wave means if you are talented, you can go up. Okay, so talented is widened, talent is widened, then you can go up. So this was your, now look at this so that is high calcium, means no one gives you bhav, so STB come, QT also come, and if you are talented, okay, so T wave may be widened. If you are talented, T wave widening. Now coming on to the next one, that is hypocalcemia. So low caste means you are down, so government tries to promote you by, that is caste, that is CA. So ST means ST will go up, QT will go up, that is your hypocalcemia. Now coming on to this hypermagnesia. This hypermagnesia increases everything, QT prolonged, PR prolonged, and QRS prolonged, hypermagnesia. Okay, so this was about hypomagnesia. Here the QRS and QT is prolonged again, but here you find the presence of hypomagnesia, you find ST segment depression. Hyperkalemia, if we talk about, recall hyperkalemia, what happened, T wave tall gaya tha, so P wave becomes flat, and so prolonged PR interval, small or absent P wave. So this was in your hyperkalemia. Hypokalemia, that is U wave ka prominent hona, was your hypokalemia wala thing. So this was about your hypokalemia wala thing. So this was about your hypokalemia wala thing, ST segment depression, and hypokalemia shows ST segment depression. Okay, so this is some other ECG which is not very important. See, now coming on to some other important ECG that may come across. See, this is the ECG, that is dextrocardiac ECG. Let's try to find it out. The first of all axis. This is one and this is AVF. Okay, when we try this, say this is negative, this one, and AVF is almost looks negative only. Okay, so what happens? This also looks negative only. So the where is this graph going? This dextrocardia graph. Okay, so this dextrocardia AVF, not very sure whether it's positive or negative. Okay, so here they show this is the right axis deviation, this dextrocardia. You remember the mnemonic, that is RALPH Ralph DO. Okay, this is your right axis deviation. So because one is negative and AVF is positive, so this is one, this is AVF. And the most important thing in dextrocardia, see, the entire lead 1 is negative, so dextrocardia has global negativity in lead 1. I think guys this helps you simplify the ECG. Please watch it once, try to solve MCQ from any source that you have, and try to apply the concept. The more questions you practice, the better it would be. So try practicing questions from your ECG, and this hope this helps you demystify the topics of ECG. Please guys, do comment, like and subscribe. If you like the content, please consider subscribing to the channel. Thank you guys.